Evidence-Based Practices in Behavioral Health presented by Dr. Kristen Savicki and Dr. Stephen Phillippi.
So my name is Kristen Savicki, a psychologist by training, and I work for the Office of Behavioral Health in the Louisiana Department of Health, and I work on children's mental health policy, best practices, quality improvements, all kinds of projects around children's mental health services, particularly those funded under Louisiana Medicaid. And my co-presenter is...
Hey, good morning. Thanks for joining us. Stephen Phillippi, professor at LSU Health Sciences Center, School of Public Health, and director of the Center for Evidence to Practice. And we'll tell you a little bit more about working in partnership with the Louisiana Department of Health and Office of Behavioral Health to move forward with evidence-based practices. But thanks for being here. Hopefully this gives you a break from the immense amount of pressure and duties you all have day to day at this point. I think I heard the head of NIH say very well this morning that if Louisiana, Alabama, Florida, and Mississippi were countries, we would have the highest per capita COVID rates in the world. So I appreciate you being here. I know you've got a lot of other things that are on your plate, and I look forward to talking and answering questions. Thanks.
Thank you, Stephen. So we're here today to talk to you about evidence-based practices in behavioral health and how you can connect your youth patients with high-quality mental health treatment. And we're sort of picking up from where Dr. Thornton left off in terms of, once you figure out the screening and you're looking for referrals, how do you, get your in the right direction? There we go. Disclosure aside, we don't have anything to disclose, so I'll move on. So in terms of our for the session, the big question is, when you identify a mental health need for a patient, what next? That's sort of the big question that we aim to with some answers with today. So more specifically, some of our objectives are to talk about what is an evidence-based practice in behavioral health specifically, what behavioral health EBPs, and I'm going to use the acronym EBP very, very liberally during this presentation. So EBP, evidence-based program, what EBPs in behavioral health are available in the state and in local communities, how you can find one in your community, how families and referring parties, including pediatric and family practices, family physician practices, can select an EBP to meet the child and family's needs, and then how we at the Office of Behavioral Health and our good partners over at LSU with the Center for Evidence to Practice, how we're supporting the scale up of EBPs covered under Louisiana Medicaid and supporting you and consumers to navigate how to find those. So first of all, I'm just going to do a real quick overview before we begin. I promise this will not go into too many of the weeds, just about the overall system of mental health services for kids funded under Louisiana Medicaid. So this is just sort of a map of the specialized behavioral health services for children that are funded under Louisiana Medicaid. There's a defined package that are covered under Louisiana Medicaid. They're covered by all the Medicaid managed care organizations. And the size of the boxes here generally corresponds to the intended level of utilization. So we want there to be easy access to low-intensity services to prevent the need for more deep-end services. So wide access to outpatient therapy, clinic-based outpatient therapy, a little less access or a little less utilization of those more intensive community-based, sometimes intensive in-home services. And then we want to limit the need for out-of-home residential treatment. Then crisis services, you see those along the side there. Crisis services should be available across all levels of care, intended to respond to an acute crisis, help stabilize folks, get them back into their regular living situation, regular level of care. And then for families who need, for families who need some extra coordination and collaboration, we can also add this extra layer of support through the CSOC program, which offers wraparound coordination to just pull all these pieces together for families. So just a quick overview of that system. Because where we have our EBP programs in Louisiana Medicaid are sort of embedded in a couple of these different levels of care. And with that, I'm going to hand it over to Dr. Phillippi to take us through what is an EBP and a lot of great information about the center's work.
Excellent, thank you so much. So I won't bore you to death with what evidence-based practices are, because I am certain you all have heard that term over and over again. We literally went at the turn of the century from having just a few articles a year on evidence-based practices to literally thousands coming out every year. So I know practice is inundated with them. The most important thing that I'll say is it just ensures the higher likelihood of better outcomes in practice. And as I tell people all the time, I am certain there are phenomenal practitioners out there, but since we can't necessarily clone them and send them all over the state, our next best option is to have evidence-based practices that we can replicate over and over again and increase the likelihood of having those great outcomes. So next slide. So like Dr. Savicki said, obviously there's a list of evidence-based practices we focus on for children and families. They all hit different age groups, are delivered differently, but just a couple of things to highlight here. We are paying attention to those that are in office and those that are also available via telehealth. Same thing with those that are on the other side of your slide that are home-based, but we've also, due to the COVID pandemic, have worked even with the home-based services to convert those into, some of them have converted actually very well into telehealth options for the safety of both the providers and the consumers. So both of those still exist, and we'll talk a little bit in more detail about how to find information on each of these. So next slide. So the Center for Evidence to Practice was literally the brainchild of Dr. Savicki and OVH, working in partnership with us, trying to figure out how can we answer the state's need for increasing the quality of care. We know that Medicaid increased access to care, but the question then became, how do we meet that access with improved quality care over time? And that's really a huge portion of what the center does, and that is certainly what it was founded to do. So next slide. So this is the conference heresy. I was actually going to have lots of fun with y'all in person and give credit for people that were really quick with their phones. But I want you to pull out your phones and I want you to type in very specifically LA Evidence to Practice. It's right there on your screen.com. So LA Evidence to Practice.com. And you will hit a landing page that looks something like this if you're on your phone. And you just click on that first big purple square, and it's going to launch you into our evidence-based practice piece. So I'll give you a couple of seconds. LA Evidence to Practice. This is a participation exercise. And then launch yourself into that first big purple square. And then we'll go to the next slide, Kristen. Now, to get to this picture on your phones, you will see at the very top, you've got those three little dashes. If you hit those dashes and you go to Community Resources, right? And you click on Community Resources, you're going to find that symbol. And Community Resources, it'll come up looking like that on your phone. If you click on that, you'll start getting into some of the stuff we do. Our task is literally training providers and helping providers get up to speed in evidence-based practice, research-informed practices and everything else, but then also helping people find them and know where they are in the state and how to make the best referral possible. So next slide. So if you click on that, you're going to see things like this one. I'm not going to keep showing you my phone versus your phone. I want you to play through this whole thing, and hopefully you won't crash our website. Maybe you will, but play with it, and you'll find things like this. So we worked really hard with Dr. Savicki and her group, especially at the onset of COVID last year, to try and figure out, without being present out in the community as heavily, how can we, in the most simple of terms and steps, convey a good referral from, and so we tried to narrow down all those EVPs we're working on. And we narrowed them down into 3 categories. So we've got people trying to recover from trauma. We've got kids and families that are trying to improve behavior around kids' behavior in the home. And then we've got families that are trying to strengthen their family relationships. And so we bucketed, for lack of a better term, all the EBPs along those lines, and some crossover. So this one just highlights strengthening family relationships, but it talks about some of the struggles families might be having. And then, so what do you do with those struggles? So next slide. And what you have is we tried. This is why I incorporate so many students from public health. This is what they do. This is what they learn, is how to convey messages via public health and use infographics to keep it as simple and as quick as possible. So this just, for example, says, you know, you've got a kid that's age of the child is somewhere between 11 and 18. In this instance, you've got other age categories that we break down as well. And then it says, here's some potential treatments, but what are the issues? So purple is that that EBP that focuses on trauma. Sorry, I'm having trouble reading my own slides. Trauma. The gold is focusing on improved behavior categories. The purple, or that dark purple, is EBPs that are focusing on family strengthening. And you'll see some have a little bit of all, some of are a little bit of different focuses. Some are very focused on only one aspect. The other pieces that you'll find on your screen is where it says you've got those little people figures in there. That says that it's still doing in-person treatment. They've got an in-person option. The phone indicates that they also have a telehealth or telemental health option. The house means it can be delivered in a in-home setting, and it also indicates whether it's got a telehealth option. Next slide. So that's just some quick way to kind of triage evidence-based practices linked by age, by possible referral issue, and then what the different treatment aspects are. For a very it's a deeper dive, but very big overview, is you go to this other option that's in there, EBP service descriptions. And this was designed for both families and practitioners, referral sources out there. Next slide. And what you'll find is you can literally pick out any one of those evidence-based practices, and it's going to give you something that looks like this. It'll tell you, for this example, functional family therapy for child welfare populations, target population 0 to 17, weekly sessions for 5 to 7 months. It's what is the focus of treatment, what are the likely outcomes if done well, and then just the general overview. So it's meant to be a very quick snapshot of that program, so families know what they're being referred to, providers know what they're referring to. And our goal, and we've done this, I think, successfully with our network, is we're trying to get people as close to the right referral as possible, but we also have a very competent referral network that says, basically, if you didn't make the exact right referral, if you didn't get that handoff exactly right, we've got really competent referrals that can say, you know what, this may be a better treatment for you than what you were referred to. Let me help you get there. And we'll show you how you can also find those other treatments as well. So next slide. This is just another example, same thing with just eye movement desensitization, reprocessing therapy. This is one of the most recent add-ons, and it's been very, very popular with providers. We have a waiting list, and we keep on doing training after training. Providers are very interested in this, but this is a very trauma-specific in ways to give relief to the trauma symptoms, but also get people to start reprocessing so that their emotional day-to-day care isn't as highly impacted. Next slide. So how do you find a provider? So we kind of triage. We know, we're looking for this kind of service. We've got these EBP descriptions. So one of our recent grads, who actually is just finished her PhD and has moved back into med school. She wants to potentially get into pediatrics or psychiatry. She hasn't made up her mind yet, but she came up with this idea, and it is probably the most utilized aspect of our website. So next slide. So if you click on the interactive map, you're going to see actually this big picture of the state of Louisiana. You can blow it up, reduce it, however you want to do it. There is, I'll just call your attention to, there's those little 2 arrows up there next to the legend. If you click on that, you're going to see this drop-down list. You can decide to look at all the EBPs. You can narrow it down to a single one, however many you want to look at. But then you can blow up to your area. So in this case, you're looking at EMDR, you're looking at TFCBT and youth PTSD treatment in the Shreveport area. And these providers pop up. Now, next slide. Now, each one of those providers has information affiliated with the center. So we pay attention to the rosters, the certifications that people have. People that have been trained and they're working towards certification. For example, this one, when it was last updated, their certification is in process. So they've been fully trained and they're trying to get to their final certification. But it gives you the agency name, the address, where they are, the contact phone number, and exactly what EBP are they providing, TFCBT in this case, so trauma-focused cognitive behavioral treatment. And then it also tells you what Medicaid plans they accept. So you don't get those kind of false referrals where you send somebody and then they get frustrated because that provider actually doesn't take the health plan that they have. So you can see that all ahead of time. And then we also keep the last time it was verified. Now, you all help us out on this. We tell consumers this, we tell providers, referrals. If you find that any of this is inaccurate, call us, let us know. Email us, talk to us. I'm not sure what just happened to Dr. Savicki, but call us, let us know, and we will reset the map. So it's meant to be interactive. And let me do this. I'm going to see if I can save Dr. Savicki. So when she comes in, we're still ready to go. Sorry about that. All right. So that was the interactive map function. Hey, Dr. Savicki, welcome back. And just in time, back to you, Dr. Savicki, but I've got control of the slides now. So, Kristen, you are frozen or I am, one or the other.
Dr. Phillippi, it looks like Dr. Savicki's video may be frozen. Dr. Savicki, if you can hear us, it may be helpful to stop your video and then unmute yourself, see if we can at least hear voice that way.
You're back.
Okay, folks, this is unfortunate. I don't know what's going on with my computer, but if I drop again, I will try a different computer and jump back in. Dr. Phillippi, am I in the right spot of our slides? Obviously, I missed where you were.
You are. You're right. And kid walks into your office end. Can you see it?
Okay, well, and this is my turn, so I really hope that I don't lose you guys again. All right. So our goal here, thank you, Dr. Phillippi. Our goal here is to talk about a couple of scenarios where you, as a physician, might be the first to identify a need for mental health treatment for a child, and how you can move then to identifying an EVP therapy that's responsive to the child and family's needs, help the family find a provider in the community, and link them to the right treatment. And am I no longer in control of the slides, which would probably—
I've got it. I've got it.
All right,
Yep.
Next slide. That's a great plan. Thank you. Okay, so we got a couple scenarios here for you, and I'll go ahead and read this one because the print is kind of small. But scenarios that might be representative of what you might see in a pediatric practice. And we definitely welcome you to jump in the chat and the Q&A, and certainly later on we'll have more opportunity as well to jump in with your own scenarios. And what are you actually seeing? What are the kinds of things you're seeing in your office that you want to be able to figure out how do I connect this kid to a good quality treatment? So this particular scenario, mom brings in her 4-year-old for an office visit based on problems at preschool. Jackson can't stay in his seat to finish desk work like the other kids in class. He has to be redirected multiple times during a task. The teacher's frustrated, and Jackson says, the teacher doesn't like me, she's mean. Jackson gets on other kids' nerves on the playground. He gets teased. He started to respond by hitting and kicking other kids on the playground. And mom reports similar issues at home. Says, he's driving me nuts. He doesn't listen to anything. He just does what he wants. He started breaking stuff when he gets mad, and he swatted his little sister last week. What do I do? So then, as a pediatrician, you come up with the question of, what do I do? What are your thoughts about screening, assessment? What diagnoses are you considering, and what's the recommended treatment? And please jump in here as docs, as folks seeing this kind of thing every day in your practice, please jump in the chat or the Q&A. So for screening, just first of all, wanted to put in a shout out to the our good colleagues with the developmental screening guidelines, the development of the developmental screening guidelines in Louisiana. Certainly want to promote the use of broad screening tools like the Ages and Stages, SE, for those kind of broad, screening of all kinds of developmental and social emotional concerns. And then, obviously ADHD is a possibility here. So the Vanderbilt is a really good option, with the another advantage that it's freely available to you, especially given that it's part of the AAP ADHD Toolkit. Next slide. And this next one is just going to remind you, if you don't already know, that the AAP ADHD Toolkit is freely available to you, the whole toolkit. It can be accessed on the Louisiana AAP website portal, which, thank you so much, the Louisiana chapter of the AAP built a whole website portal in order to host this for Louisiana docs. And that's funded by the subscription for the use of the toolkit is funded collaboratively by all of the Healthy Louisiana Medicaid managed care organizations. And so the links there on the screen, actually just put it up in the chat. That's awesome. Great. Okay, next slide. So in terms of diagnostic considerations for our friend Jackson here, we all know that behaviors like his in a 4-year-old can mean a lot of things. We've historically, in the healthcare field, and then specifically here in Louisiana, we've historically overdiagnosed ADHD for certain types of kids. Certainly 4-year-old boys are a case in point. But we've also underdiagnosed ADHD for other kids. So for instance, ADHD is often missed in teen girls. So Jackson's troubles certainly could be driven by a neurodevelopmental condition like ADHD, could be driven by anxiety or trauma disorder, could be environmental factors like toxic stress, inconsistent or negative parenting, or all of the above. And tools like the Vanderbilt, along of course with your interview and other diagnostic tools, are going to help you sort this out to some extent. But here's the good news for Jackson and his mom. Some of the EVPs that work with kids his age can really be effective and helpful for him, no matter what the underlying drivers are for these behaviors. And we'll talk a little more about why that is in a minute. It's also good news for busy physicians. If you're able to head Jackson and his mom in the right direction, the mental health provider can take it from there and help him, whether his troubles are coming from ADHD or anxiety or inconsistent parenting or all of the above. Next slide. So just on the subject of ADHD, here we have it directly from the AAP guidelines on treatment of ADHD, that the evidence-based behavioral therapies for preschool kids with ADHD, they have the advantage of benefiting kids with similar presentations like disruptive behaviors, regardless of the etiology of that behavior. Next slide. And just again, keeping on the ADHD train here for a minute, as you know, the AAP guidelines for treatment vary by age. So for Jackson age 4, the evidence-based behavioral therapy is the first line of treatment, with medication coming in as a second choice if the behavioral therapy either isn't working or isn't available. So we've been working on that availability piece. We still have work to do, but we're making progress, as you saw in some of the information that Dr. Phillippi was showing. You'll find this on the map that Dr. Phillippi was showing you. we want you as a physician to have the tools you need, to have the tools available to you. And in the case of 4 to 5 year olds with ADHD, we want to give you access to community resources for that first line treatment of behavioral therapy. And then for school kids, for school age kids, medication is considered the first line of treatment and or evidence-based behavioral therapy, preferably both. So we certainly want to make these behavioral therapies available to kids kind of across age ranges. Next slide, please. Okay, so what is this evidence-based parent-administered behavioral therapy that the AAP guidelines talk about? And where do you find it? So this is actually taken from a handout from the CDC, which has a lot of useful tools as well to use in your practice with parents. And this one talks about finding a therapist and helpfully lists several evidence-based treatments. And these include 2 EVPs that we're working on building up here in Louisiana under Louisiana Medicaid. And those are PCIT and P. Next slide. So PCIT has been heavily researched for many years. And this, for example, I'm just using here a meta-analysis that was published in Pediatrics in 2017. It talks about some nice results from this meta-analysis in terms of reducing child externalizing behaviors, reducing parent and child stress. Kids in PCIT were observed to be more compliant with parent requests. So all good things. Next slide. And then also just to talk for a second about P, which is the Positive Parenting Program. P actually offers a whole suite of interventions that start with really low intensity self-help materials in book form and web-based, moving up to group-based programming and then individual treatment interventions as well. Under Louisiana Medicaid, we're working on a version of P that's delivered by a clinician individually to the parent and child dyad, where a diagnosable problem requires treatment. And so that's in contrast with some of the lower level, more preventive versions of P, which are also available in the state, but they're not they're not a Medicaid fundable therapy. So similarly to PCIT, research on P shows good results. This is just an example of a research study showing that moms in the P group had improvements in parenting style, improvements in mother-child relationship, decrease in depression, anxiety, and stress, and reported lower rates of child misbehavior than women in the control group. Next slide. So just a couple quick notes on why these work. What are these treatments doing and how do they work? The principles behind them are very similar. As is developmentally appropriate for kids, especially for preschool age kids. They focus primarily on working through the parent-child relationship, since the parent-child relationship is the most important and powerful factor influencing a child's well-being. And so we know all of these things on this slide about kids, that these early experiences are really crucial. Those relationships with primary caregivers can buffer a lot of different impacts, particularly of trauma, which is incredibly important now, now more than ever. Next slide. These parent-focused programs, PCIT and P, they work in similar ways to improve the parent-child relationships and harness the power of those relationships to reduce and manage difficult behaviors. This image on your screen is actually taken from a whole different parenting program called The Incredible Years, but I include it here because it's a nice image and the principles are the same. The different EVP programs package and deliver these interventions in slightly different ways. They're all basically working to accomplish the same thing, which is to expand use by parents of those positive relationship building skills, such as play and praise and incentives, doing targeted use of limit setting, ignoring annoying but safe behaviors, and then limited use of those more kind of consequence-based timeout type of interventions. So that was disruptive behaviors scenario. Certainly, as Ashley noted, pop into the chat with questions, comments, feedback. But I can go ahead and move on to the next scenario, but we can circle back if anybody is wanting to comment on that one. So scenario number 2. And this one, full disclosure, I pulled directly from the AAP's trauma toolbox for primary care. Again, I'll read it since it's kind of small print. So in this scenario, we have Emma. who's a previously healthy 15-year-old girl. She's with her mother. She presents with abdominal pain and nausea for the past 3 months. She lives with her mother and stepfather and sister. Her examination is completely normal. Her parents want to know what the problem is. They're requesting referral to a gastroenterologist. Before making the referral, you talk to Emma alone without her parents in the room. She discloses that she has a history of long-term sexual abuse from her biological father, who she does not have contact anymore, from 6 to 12 years of age. 1 year ago, she took an overdose of over-the-counter medication, was hospitalized. She tells you that talking about these things really upsets her mother. And additionally, she discloses that she's being bullied at school. So again, in this scenario, what do? What are your thoughts about screening and assessment? What diagnoses are you considering? And what treatment are you looking at? Next slide. So along with the scenario, I also took the recommendations in this slide and the following slides directly from AAP materials from the Trauma Toolkit for Primary Care, which is great information on becoming trauma informed in your practice. The AAP Toolkit shows ways which PCPs may identify trauma needs in practice and how to respond. But the first guidance is this, and I just really like this, so I wanted to pull it out. The suggestion that given what we know about the prevalence of trauma, that it's reasonable to consider trauma at every well child visit and to have a high level of suspicion of trauma during any problem-focused visit. So that's really just the first step, is maintaining that high level of suspicion. Next slide. So here's another example from some of these AAP materials, looking at this table of symptoms that may well be responses to trauma, along with information about what may be misunderstood as the causes of the symptoms if we fail to exercise that high level of suspicion about trauma. Next slide. So as per the AAP guide, there's not necessarily a validated brief screening tool for trauma that's going to work all the time and is practically to use in primary care. Now, a caveat to those AAP guidelines, there are screening tools you can use, and you're going to hear more about those and way more great information about how to build a trauma-informed pediatric practice at the session later today with Drs. Hinshaw, Kelly, and Middleton, and I'm really looking forward to that this afternoon. But sometimes your best tools are going to be just questions. And here are some of the questions, the open-ended questions that AAP provides as examples of questions you might ask. How's your home life changed? Has anything bad, sad, or scary happened to your child recently? How do you deal with stress? Some of these open-ended questions that might help generate that conversation and can help you work with kids and parents to identify needs related to exposure to trauma. Next slide. So then what to do? We know that primary care docs may be concerned about uncovering trauma needs unless you also know that there's a way to connect your patients with the help they need. And that's where our recent work on building up EVP trauma treatments in Louisiana comes in. So first of all, the AAP provides some guidance on when to consider a referral to therapy. There's no hard and fast rule, and we do want to note that not all children need or are ready to engage in trauma treatment. But for some kids and families, getting to the source of the problem, the trauma exposure, that might be driving other symptoms and behaviors that are going to continue to harm the child, that treatment can be deeply needed and can really lead to recovery. Next slide. So what are the EVPs that can help? The AAP guide also includes this nice table outlining some of the evidence-based interventions that are recommended for trauma treatment. And conveniently, all the ones listed here are EVPs that we're working on training and expanding under Louisiana Medicaid right now. So there's reference here to PCIT again, which we talked about in terms of disruptive behaviors, but because it works through strengthening that child caregiver relationship, it can also help kids recover from trauma as well. There's child-parent psychotherapy, which is really for the parents, an infant or toddler dyad. It's really for really little kids and their caregivers. And it directly addresses the need to repair that child caregiver relationship, attachment following the trauma. And then we get into some of the interventions that work for school age kids. We look at trauma-focused cognitive behavioral therapy, which is TFCBT. And then in addition to this list here that came from the AAP guide, We in Louisiana, we've added a couple more. We have a PTSD treatment program, including versions for both preschool age and for school age kids. It was developed and tested by Dr. Skringa at Tulane. And we've also started, I think Dr. Phillippi noted before, we've also started building the workforce for EMDR therapy, which is often better known as a treatment for adults, but can be effectively used with adolescents and even younger children. Next slide. So one more time, just kind of getting into a little bit of the clinical stuff about how these work. Much like the treatments for disruptive behavior disorders in little kids, a lot of the trauma treatments share some common factors. So they often begin with psychoeducation, and this slide is taken from TFCBT, but there's a lot of similarities across a lot of these different EBP programs. They often begin with psychoeducation to the client and to the caregiver about trauma responses. So the child understands that their responses are normal human responses to trauma. They're not crazy. These are, this is sort of how the body responds, how the mind responds to traumatic situations. Then they typically teach clients new skills for regulating and coping with emotions that can be overwhelming in response to trauma. So you'll see that here in the first phase of TFCBT. They teach relaxation, they teach emotional regulation, cognitive coping skills. And then these treatments often move to helping clients work through some form of exposure to their memories of the trauma by either reimagining the traumatic events or retelling the story of the trauma. So TFCBT, the way this treatment does it, is that they help kids tell their trauma narrative. And the goal then is to help clients process those memories in a different way and restructure their thinking and their response to the traumatic memories and make a different meaning out of that traumatic experience, which can bring a lot of relief to some of the overwhelming feelings and then kind of resulting behaviors that can happen. And then for kids, of course, there's a huge level of importance in working with the caregiver. You'll see that in TFCBT. There's work throughout to help parents understand the trauma, help parents with parenting skills to support their child, and then conjoint sessions where the therapist works with the child and the caregiver together. Next slide. And then the last shout out to the AAP trauma toolkit, which just has great stuff. It also includes this downloadable visit, discharge, and referral summary to help pediatricians organize and make that referral. You can tell me if you think this it would be useful to you in your practice. It looked great to me because you get a chance to check off the assessment findings. These are the symptoms that I'm seeing from this child in my office. These are the things that need to be addressed. You can talk about developmental or medical issues. You can select specific recommendations, date for a follow-up appointment. You can add, phone numbers of particular, community agencies that you're referring to. So basically, it provides a lot of great information to put in the hands of the family, among other folks, so they feel confident in providing the right information to the professional that you're referring them to. Next slide. So this is where we get into your scenario or kind of general question and answer, any comments or feedback here. Those are two scenarios that we came up with that we thought these might be the kinds of things that you might see of a kid walking into your office that you might want to know what's out there in the community that I can connect this child to. Really interested to hear if folks have other scenarios, other situations where a kid walks in, a parent walks in with a particular presenting problem, particular complaint, and then where to go from there. What can you connect those kids and families to? And then again, obviously we got time for other question and answer as well.
Dr. Savicki and I are trained therapists. We can wait. I would also be curious from those of y'all listening and participating, what about this works for you in your practice? What of this doesn't make sense? Because we certainly can learn as well. Neither one of us are pediatricians, so trying to appreciate more of your world and your experience would be great.
We do have something that's been entered into the Q&A. Dr. Holly Gill says, I have seen a huge improvement in access to counseling and quality of counseling, but there remains a huge gap for children needing medication that are on Medicaid. She was going to send an example as well, but if you guys had thoughts on that.
I'll say, first of all, that's great to hear about the improvement, and I'd certainly love to hear specifics about what folks are seeing in terms of improved access and improved quality. That's certainly our goal, and we know that it doesn't always translate in practice, or folks don't always see it on the ground, so that's great to hear. We don't, our group here is not specifically working on the medication side. There's, kind of policy and practice on the whole pharmacy side, and I'm not a prescriber myself, so I can't really speak to the medication piece.
I could just simply add what we're seeing at the Health Sciences Center in terms of who we're educating now. 2 years ago was the first time in many years where the psychiatry cohort was absolutely full. There was a big dip nationally in psychiatry, interest in psychiatry, and it is full. So we are about to start seeing entire full classes and residency moving out of psychiatry. So it's not immediate, but long term, psychiatry is looking better and better. So that's a plus. And the other thing that we're also seeing is the addition of nurse practitioners has really helped the field, especially psychiatric nurse practitioners. And I know those programs are very attractive and very full as well. And part of it is it's a lot of people are describing it as a great way to have a livelihood in medicine, where you're not constantly on call. You kind of dictate your hours. It's much more in control. It's much more family friendly. Is how it's being described by the faculty and those graduating. So anyway, the future is looking bright. It's just not here yet.
So Dr. Gill added a 15-year-old with Klinefelter's and with intellectual disability was refused treatment from a Shreveport center because of his disability. He's got significant behavioral concerns. Where do I go for help? There's also a difficulty in finding help for older autistic children with behavioral problems.
So a couple things that I'll add there. We will get our, I think the last slide includes contact information. So I do encourage folks to certainly reach out to me directly on specific cases with specific questions. Because we can't get into obviously specific client information here. And the questions that you're raising are very are specific to kids with intellectual disabilities, also with autism, which are obviously become very complex needs that oftentimes are not addressed directly by some of these mental health services, that they are better addressed by developmental disability services, by ABA, certainly as an intervention for kids with autism, but obviously ABA works a lot better for younger children. It is less, it doesn't have quite the same effect oftentimes for older kids. So the autism issue is less what we have focused on across the center, because there's other folks working on the interventions for autism and related to developmental disabilities, but certainly email me and I can connect you to folks where that's more a part of their expertise. Sorry, one more thing. I will add that a project that we're going to work on over the next year, in fact, is looking at which of the evidence-based interventions that we've worked on developing a larger workforce for all kids in the state, which of those can also be effective for kids who have a co-occurring intellectual disability or co-occurring autism spectrum disorder. And there's some great research out there on some of these EDPs and how you can use them effectively for kids with mental health psychiatric needs as well, specifically the trauma treatments. There's a huge level of trauma, we know, among kids with intellectual disabilities, And a number of these trauma treatments can be used effectively with kids with intellectual disability. And so a project that we've talked about with our colleagues at the Office for Citizens with Developmental Disabilities is we've talked about doing some co-training, doing some specialty training for clinicians who do some of these, specifically the trauma EDPs, some of the other EDPs, on how can you adapt those well? How can you use those well with kids who also have an intellectual disability? And so we haven't added that piece in yet in terms of some of the training that the center has done, but that's kind of a next step that we're looking to designing, planning, implementing. Hopefully within the next year, we'll be able to get started on some of that specialty training for kids who have, in addition to their trauma needs, behavioral health needs, may also have co-occurring intellectual disability or autism spectrum.
And I would just add to that real quickly that part of the reason all this works is the evidence-based practices, they're skills-based. So when you look at the outcomes affiliated with these, it's not just psychological relief, but there are different cognitions, there's different behavioral skills. And so if you really wanted to see the difference between somebody that gets an evidence-based mental health approach, what I tell providers, the outcome is you should see behavior changing. And that goes both for the youth and also their caretakers. So if you're not seeing behavior change, then you're probably not affiliated with an evidence-based practice. There's lots of talk therapies out there. There's nothing wrong with it. It gives you some emotional relief, some catharsis from all the stuff that's going on mentally. But if the end result of all that talking doesn't lead to changes in behavior, then you're probably not linking to an evidence-based practice.
And thank you to Dr. Hinshaw, who added some information in the chat about some resources specific to autism.
Scan the QR code or go directly to the link to complete the evaluation and claim your education credit. Please reach out with any questions you may have.